Yes, people. Tachyarrhythmias, its diagnosis. Okay. And and okay, tachyarrhythmias. Can someone tell me types of tachyarrhythmias we have discussed? Types of tachyarrhythmias we have discussed. How to read ECG. Okay. That is the course. We are studying that only. What type of tachyarrhythmias we were, are there, right? Because that is the common class. We have already studies. What are the types, guys? Only one is writing. Narrow QRS, broad QRS. That is tachycardia, right? Okay. Broad QRS tachycardias, narrow QRS tachycardias. Okay. Anything else in that? Yes. Anything else in that? Supraventricular, ventricular. Okay. And supraventricular, ventricular arrhythmias. Then, yes. Then what else? Yes, guys. Then what else? Just putting it on charger. Okay. Regular, irregular. Remember, regular, irregular. What is the regular, irregular? Regular, irregular. Do you know regular, irregular also we have discussed? Okay. So, anyways, let's start. Okay. Let's start the class. So, let me come to the class. Yeah. So, here, today we are talking about two tachycardias, sinus tachycardia and atrial fibrillation, because this is very tough, like to discuss everything in one, right? So, can you identify which tachycardia it is? Guys, identify this tachycardia and tell me the heart rate. Yes, tell me the heart rate. Yes, which tachycardia is this and what is the heart rate? See, I'm telling this is a tachycardia. I'm not asking which arrhythmia. I'm just directly asking which tachycardia. It is tachycardia. So, write the heart rate, calculate the heart rate, and tell me. Yes, guys, tell me. Tell me, guys, fast, fast, fast. Yes. Okay, you're answering. Let me see. 100 BPM. Okay, only one person has calculated. Guys, everyone, what are you doing? Calculate. You want to see that again? See here. See here. Calculate the heart rate. Calculate the heart rate and tell me which tachycardia is this. Atrial flutter, 150 BPM. Daisy, okay. Anyone else? No idea, guys? Come on. You're studying, right? We have discussed many arrhythmias, right? Then, okay, let me show you again. See. So, first of all, what you will see here is heart rate. First thing, what you will calculate is heart rate. So, heart rate is around 110, 105, right? 110, 105, because it is completely, there are three big boxes, one, two, three. Like, R to R interval is three big boxes. So here only big boxes are seen, not small boxes. Okay. So if three big boxes means like 100 to 110, somewhere it is three, somewhere here it is 2.5 or 2.6. Right. Here it was again like little lesser. So the thing is the heart rate. Heart rate is definitely high. So it is tachycardia. Now the again one important thing here you will see that the regularity. Okay, regularity. So you will see, right, guys, listen to me carefully how to identify arrhythmias and how to differentiate here, right? So you will see that the distance between R to R is almost similar, right? So this is regular tachycardia. Okay, the rhythm is regular, right? Rhythm is regular. There are no ectopics. Ectopic means missing beats, right? There are no ectopics. First thing, heart rate is high. Remember that. Then the RR interval is similar. RR interval is similar everywhere. So this is regular arrhythmia. Okay, regular arrhythmia. I mean regular tachycardia. So normal tachycardia. No, I mean I cannot say normal tachycardia, but like it is like standard tachycardia. Okay, standard tachycardia. There is no changes in the distance RR interval, right? So RR interval is similar. Then the one more very important thing, the basic, line or baseline means this line should be straight, and at the base should be here only. See, the whole wave, I mean there are T waves, P waves, R waves, and full QRS complex which are going up and down, lot of things. But the baseline electromagnitude line, remember that electromagnitude line is at the same, it is constant, it is not going up and down, it is straight. Okay, it is straight, right? Everywhere, if you see, this is straight. Electromagnetic line is straight, right? See, everywhere, the whole line from here to end, right? From here to end, it is, similar, right? One second, how to pointer. Laser pointer. Okay, yeah. So if you see from here to here, anywhere from here starting to end, the baseline is straight, right? So this means like everything looks normal except heart rate. Heart rate is very high. Heart rate is very high. But here, if you look at other things like the electromagnitude baseline is straight, distance between RR is normal, right? It is similar. It is like there is no changes, there is no intervariable, right? And the third thing, there is no missing beats, there is no block, right? So everything looks, the circuit looks normal. The circuit looks normal. And the fourth thing, which you must remember this, like all the rhythms are perfectly normal. Rhythms normal means like P, P, QRS complex ST, right? P, QRS complex T, P, QRS complex T, P, QRS complex T. However, see, distance may be less between R and R, but P, QRS T, everything is intact. There are no changes. There is no upward or downward. There is no, this is not wide QRS or narrow QRS. This is normal. This is normal QRS. This is not narrow QRS. This is not wide QRS. This is a normal QRS range. Okay, this is normal QRS range, which is usually 80 milliseconds to 100 milliseconds. Okay, 80 milliseconds to 100 milliseconds. The whole thing QRS complex is normal here, right? So now note down these parameters when you check any ECG. Maybe you are not remembering in the classes, I don't know, but I have told you many things in the past classes also, but you are not remembering, you are not answering at all. That I don't know why. Okay, but here, remember these things when you are looking at any ECG. First thing you will see, if you are looking for arrhythmia, first thing you will see heart rate, if it is normal or not, like you can calculate easily. Okay. Second thing, you will look at the electromagnitude baseline. If it is correct or not, then you will look for ectopics, like if it is block or not. If the electric circuit is proper or not, then you will look for, QRS complex and the waves, if the rhythms are, consistent or not. And then if the p value is consistent or not, if the p value is present or absent, because absence or p value directly leads to very severe arrhythmias or harmful arrhythmias where there is no p value. Okay, I mean, sorry, not p value, I'm so sorry, p wave. Okay, here p wave. So if there is no p wave, then it can lead to atrial flutter or atrial fibrillation. Okay, if there is no p wave absence is the signal of p wave, absence is the signal of atrial fibrillation or atrial flutter. Okay, so there are everything intact, right? So if everything is intact, these five parameters, if you check, you can easily diagnose arrhythmia. Okay, you can easily diagnose tachyarrhythmias and arrhythmias. Okay, so first thing heart rate, then ectopics, then rhythm, and then your QRS complex, and then your P wave, and then your magnitude baseline. Okay, if you remember these parameters, you can easily identify the arrhythmias or tachyarrhythmias. Okay, so if you're not learning this, then I cannot help you literally. Okay, so now you look, all everything is simple. That means this is a normal tachycardia. I mean, normal tachycardia means standard tachycardia, which is we call sinus tachycardia. Okay, sinus tachycardia means just because of the impact on sinus, just because of the impact on sinus, the speed of impulses has increased, but there is no fault. Okay, there is no fault. It is just because of certain reasons. Sinus tachycardia means everything is fine, just your heart rate is abnormal, just your heart rate is high. Okay, that is not also irregular, inconsistent. No, everything is perfect, just your heart rate is high. So that is called sinus tachycardia. Understand, that is called sinus tachycardia. So you understand here easily, sinus rhythm like less than I mean, it's normal, it is like 60 to 100 beats per minute, right? When it is sinus bradycardia, it is more than 60 beats per, I mean, sinus bradycardia less than 60 beats per minute, here you can see easily, and sinus tachycardia more than 100 beats per minute. But here this is not just showing the beats, it is trying to show that the electrical, electromagnitude baseline, electromagnitude line is straight. Okay, QRS complex is normal. Okay, QRS complex is normalized, and then there is no ectopic beat. There is no problem at all. There is P wave, proper P wave, right? So it is showing all the parameters, and the normal difference you can, understand between tachycardias, bradycardias, and normal rhythm. So when it is sinus rhythm, it is normal. When sinus bradycardia means the heart rate is less. Okay, heart rate is less, but nothing problem. Okay, and sinus tachycardia, heart rate is high, but there is no specific fault in cardial, I mean, in the sinus node, or sinusoidal node, or in in any circuit. Okay, or any part of circulation system, sorry, any part of, yeah, electric circulation system, right? So now, next thing is to understand sinus tachycardia. What is sinus tachycardia? Simplest and common one. Heart rate is more than 100 beats per minute. Signals are defected from SA node. Signals are defected means getting high. There is no fault in the arrhythmia. There is no fault in the circuit. There is a fault in that SA node is SA node is facing the impact. Okay, and that impact could be results of stressors like fear. Okay, in the fear, your heart rate can go high. Okay, and it can go very high actually. Intense exercise, it can go high. Or not drinking enough fluids. You understand? Not drinking enough fluids. Dehydration can lead to sinus tachycardia. You must have felt, every one of us usually feel, even I feel, whenever I am stressed, whenever I am working to late night, or whenever I am drinking less water, or maybe I am running fast. So I feel, oh, my heart rate is getting high. So that is like, there is no specific problem, but due to the sinus node impact, that the problem, the heart rate is raising. That's all. Heart rate is rising. That's all. Nothing much, right? And that can, there are specific stresses like fear, intense exercise, not drinking enough fluid. Other factors which could be like your drugs, like drugs could definitely lead to tachycardias, majorly sometimes your antibiotics, sometimes your what we say, endothelial receptor antagonists, or maybe hormonal imbalance part can be lead to this. Okay, immunological drugs can lead to this. Okay, so tachycardias and HIV drugs can lead to it, right? So there are the drugs which can cause the tachycardias. And then fever also can lead to tachycardia. Okay, infections, anemia, heavy bleeding, even in the menstrual cycles, heavy bleeding can lead to your tachycardia. Then hyperthyroidism, damaged myocardium, these all can lead to sinus tachycardia. Okay, so if the cause of your sinus tachycardia is unknown, it is called inappropriate sinus tachycardia. Still, the problem is not serious. Okay, Still, the sinus tachycardia as a problem is not serious. Understand? So, what are the causes? Now, case one is the simple case. Can you please tell me what is this? What this ECG shows? Okay. And can you identify? This is a challenge. Can you identify like what kind of arrhythmia it is? What kind of tachycardia it is? This is the case one. So over to you guys and please participate. Otherwise, there is no use of teaching literally. This is a practical class. I am telling you, I'm coming up with the cases. I'm teaching you, very basics and deeply. Still, if I'm not getting answer, I'm disappointed. Okay. So what is case one tells? Tell me guys, what is this ECG? Shows. What is this ECG shows guys? Tell me. You will be surprised like what this ECG is exactly. Yes, tell me. Yes, people. Tell me fast. Yes. Check. Atrial flutter with 2 into 1 AV conduction. Okay. Irregular tachyarrhythmias. Irregular tachyarrhythmias. Okay. 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 Let me this open this at so you can easily uh, understand where I can get it here. Yes, now I can see your comments also. Yes, irregular tachycardia with heart rate 110. Only two people, three people, sinus tachycardia, heart approximate 120, irregular tachycardias, atrial flutter 2 into 1 AV conduction. 2 into 1 AV conduction, where did you see, dear? Bhargav Samant. Bhargav Samant, where did you see 2 into 1 AV conduction? Tell me. 2 into 1 AV conduction. Oh my God. You have studied too much. You have studied too much, literally. In that case. Irregular tachycardia. Irregular tachycardias. Who is telling irregular tachycardia? How you can say irregular tachycardia, Utkarsh? Justify. Sinus tachycardia, irregular tachycardia with the heart rate of 110. Okay, heart rate of 110 can be considered, but how irregular? Tell me, where it is irregular tachycardia? Remember this. It will be useful for you in the future slides today only. Okay. Sinus tachycardia. Tell me, guys, first. Anything else you can find out? No? Okay. Let me tell you. So, this is tachycardia definitely because the heart rate is around 110 and this is nowhere irregular. Where it is irregular? See, if you look at the lead one, see there is a P wave, QRS complex, similar QRS complex, P wave, similar QRS complex, P wave, similar QRS complex, P wave, similar QRS complex. The waves are down only QRS complex in that the R is downward only in AVR. Okay, in AVR, R is always down, downwards, right? So this is not irregular. Okay, this is perfectly fine. And if you look the heart rate, if you look at the QRS complex, if you look at the magnitude line is completely fine. See, the line is completely fine, straight. It is completely straight. Okay, it is completely straight line, normal line, no ectopic beats. There is no 2 into 1, 1 into 1, 3 into 1. There is no ectopic beat at all. There is no missing beat. Okay, there is no missing beat. Nothing is there. There is p value present in everywhere, right? P value everywhere. If you see everywhere, p value is there. Okay, QRS complex is intact. Okay, distance between R to R is intact everywhere. It is consistent. And the no ectopic beats and the magnitude is this electric magnitude line is similar or straight. So it is simple sinus tachycardia. Okay, sinus tachycardia with 110 of heart rate. Okay, But other than this, there is another question, guys. Okay, I will come to the second case, but there is another question for all of you. There is another question for all of you. Can you please tell me? Can you please tell me, like, can you please tell me that what could be the reason for this tachycardia? This is a case of a 29-year-old man, 29-year-old young boy, if I say. So that is the case of a 29-year-old boy who came to the hospital with fever. Okay, he came to hospital with fever, and at diagnosis, he was diagnosed with H1N1. Okay, H1N1 influenza. He was diagnosed with influenza and he got this ECG. So, what could be the reasons for this ECG in H1N1? Right, you have to tell me this. What could be the reason, pathophysiology or anything? What could be the reason? His fever was 102. Okay, when the ECG was taken, fever was 102, the temperature of the body was 102, and he was diagnosed with H1N1. Okay, and his heart rate was 110. So that time this ECG was taken. It is completely sinus tachycardia. Okay, but why? Why, guys? Why? Tell me. Tell me. Increased metabolic demand due to, okay, fever due to virus. Okay, reason for sinus tachycardia. Reasons for sinus tachycardia: regular rhythm, narrow QRS, P. Okay, fine. Increased metabolic demand, vasodilation. Okay, increased metabolic demand. Quite good. Okay, due to some anxiety. Uh, okay, but okay, so note down. Okay, when it is a fever or infection, so there are specific pathophysiological terms. First is temperature driven increase in heart rate. Okay, temperature driven increase in heart rate, and that is because of when the fever raises, metabolic rate raises itself. Okay, fever raises, metabolic rate raises, and then the body needs more oxygen, right? So more oxygen demand is there, and heart compensates the oxygen by pumping faster. Simple one. Okay, the heart compensates by pumping faster. Okay, so this is not exactly hypoxia, but when the fever raises, the metabolic rate raises and more oxygen is demanded, right? So there is no breathlessness. Understand, hypoxia is breathlessness. Okay, due to hypoxia, there could be breathlessness, but there is no breathlessness right now, right? That is inside the body. When the body temperature is rising, body has to compensate, heart has to compensate by pumping faster and distributing more oxygen supply, right? That is your heart rate increases, the reason for heart rate, increased heart rate, reason for tachycardia. Okay, and you know the fact that every 1 degree rise in temperature, at least 8 to 10 heartbeats will be increased. 8 to 10. If your heart, if your fever increased like from 99, it go 98.6. If it goes to 102 or 103, means your heart rate can raise up to 50 to 60. It can lead to 100 or 110. Check it sometimes. Try it. Okay, anywhere in the patients or in yourself, because that is because of your body temperature and metabolic, your metabolic rate increment, right? And that is because of your more oxygen demand. Okay, and the second thing is sympathetic nervous system activation. So this is, again, there could be a little bit infection triggers the stress. Okay, triggers the infection, triggers the stress, and then the catecholamines in the brain will increase, like epinephrine or norepinephrine increases in the body. Okay, increases in the body, and they stimulate the SA node, and it raises the heart rate. Simple, and causes the sinus tachycardia. Okay, and there could be the another reason, hypovolemia and dehydration. Okay, hypovolemia and dehydration. So fever leads to the poor intake of food, poor intake of water, and it also leads to sweating, and because of that the intravascular volume of water or intravascular volume actually decreases, and because of that the cardiac output also decrease, and the heart tries to compensate that. Okay, and because of that your SA node will be pressurized, and definitely your heart rate will be increased. Okay, understand? So these could be the major regions, major pathophysiology. And other than that, toxins or maybe some inflammatory responses, infections could be the reason for, you know, increased heart rate. Okay, increased heart rate. Now there is a case number two. Now there is a case number two. Now tell me what is this? Case two, guys, case two. Tell me what is this? Tell me what is this? Yes, people, this is really good. This is really amazing. Tell me what is this? Tell me what is this? Yes. Tell me what is this, guys? Okay, let me make it small and let me take your comments. Yes, tell me. AF. AF. Wow. Okay, AF. Okay. Who else is supporting AF? Who else is
No,
supporting? Yes. Someone wants to speak? Who is telling AF? Please justify. Or anything else? What is this? First, calculate the heart rate in this.
hello, sir.
Yes.
It's atrial fibrillation because of irregular rhythm and absence of visible P wave.
Absence of visible P waves. Okay.
And there
And
is also QRS segment is very narrow
QRS segment is very narrow. Okay. And anything else, guys?
and very fast ventricular rate at the end.
What is the ventricular rate?
It's very fast,
Check. Very fast means how much? Calculate. Narrow QRS
around
tachycardia.
150 to 180.
150 to 180. Calculate. This is simple. You know how to calculate HR, right? Calculate. Guys, how much it is? 150 to 160. Okay. Are you sure it is 150 to 180? See, guys, you don't know how to calculate the things. That's why I kept this ECG. This ECG is the ECG of a 22-year-old boy. 22-year-old boy. Okay. Who just came out of the gym. Okay. Who just came out of the gym with intense exercise. That's all. And this ECG is perfectly normal. There is no AF, there is no P wave absent, there is no irregularity, there is no, I mean, there is normal PR interval, there is no normal RR interval, there are no, I mean, normal P waves, regular rhythm. Yes, narrow QRS complex is there, heart rate is high. But other things, if you look at the ECG, can you please say anywhere that it is irregular? Look at the baseline, like look at the electrical magnitude line. It is completely straight. What I'm saying, it is completely straight, completely from starting to end. It is straight. Look at this. See, if you are seeing that it is not straight, look at this. From here, look at this, completely straight. From here also, look at this base. Look at this base from where the ST is generating upside. See, at the same line point, okay, same line point. How can you say that there is no PVC? Line is generating here, line is generating here, line is generating here, line is generating here. There is no Q. See, all QRS complex and each wave is similar. See, this, this. Look at this. This also, look at this. Similar straight line. Okay. Count the HR. It is consistent. It is, see, 2.5, somewhere around 140, 150. Here, around 150. Here also, around 150. See, around 150. Yes, it is around 150, 160. Here also, 150. Here also, 150. There is no irregularity. Like if you're checking one or two waves, I mean one or two small boxes, if you tell that inconsistency, not at all. Okay, I'll show you how the inconsistency looks like. And you have seen the 1 to 2 to 1 and 2 to 2 ratios, cardiovascular, I mean cardio blocks, cardiac blocks, the blocks you have seen already, right? So you see the inconsistency. There is no inconsistency at all. Everything is intact in this ECG. Okay, that's why otherwise you will send the patient into coma also. As I told you, always don't just look at this, calculate. This ECG is perfectly normal except heart rate. Where is no p value? Tell me. Here, here, where is no p value? Tell me. This is p value. Everywhere it is p value. Here, here, here. Where is here, here, here? Where is no p value? Here it is. See, where is not visible? Here, here also it is p value. See, you can see p value here. Here p value. See here p value. Here it is p value. Here it is p. Sorry, I mean p wave. P wave. See here p wave. Here also it is p wave. Everywhere it is visible. If there is no p wave, that will be straight line, flutter, complete flat line. Right? Everywhere it will be flat line. Check here p value. Sorry, p wave. I'm so sorry. I'm just confusing with the p wave and p value. I mean, just because I just took the statistics class, right? Okay, so see p wave. Everywhere it is p wave. Straightforward line. There is a QRS complex, similar QRS complex, no inconsistency at all. This is just a person who came out of the gym with exercise and with tachycardia. Okay, you want to see the uh, irregular wave? You want to see the irregular ECG? Check this. Check this. Identify which tachycardia it is. You wanted to see irregular, right? See irregularity here. This is irregularity. This is irregular, not that. This is irregular. Tell me which arrhythmia is this? Yes, I'll go back to that later. Tell me this arrhythmia, which arrhythmia is this? Identify the tachycardia here. I'm telling you from the starting, you have to calculate. You have to look very closely. ECG, reading ECG is not at all a easy task. By looking at the ECG, if you cannot find out the problem, there is no use. I'm telling you, there is no use. Let me make my camera on first. My camera is off by the time. Okay, so look at this. Where you are seeing the previous ECG was perfectly fine. You have to check the abnormality. You should know the difference between abnormality and normality. Check. Where is normality? Where is abnormality here? Here, tell me where is P wave. In this, can you identify P wave? P wave? There is no P wave in this. Not at all. Tell me in which rhythm you can see the P wave. Tell me. See, straight, no P wave. Straight, no P wave. This is T. No P wave. No P wave at all. See, no P wave at all. No P wave anywhere. No P wave. No P wave in this. No P wave. Straight line. Okay, no P wave. This is not P wave. This is flutter. Okay, this is flutter. When you see the F wave, W wave, the U wave, T, U, W, F waves, these are flutter waves. These are not P waves. Okay, these are flutter waves. See, check. There is no P wave. Where is the P wave? See, if it is like T is here, QRS complex, T, F, T, U, F, flutter waves. All flutter waves. No P wave at all. Completely P wave absent. Look at the line, magnitude line. Here, then here, then here, then here, right? Then here. Look at the magnitude line. Is it straight? If I keep this straight, it will go like this, right? Is it matching? Nowhere. 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 It is matching nowhere. If you look at this from here, suppose I start from here. Are your all the waves matching or catching this? No. No. See? No. See? Here they are matching and first one or two they are matching. No, they're not matching at all. No P wave, no magnitude line is straight. Regularity, check the heart rate. Where is heart rate? See, here it is around maybe 200. Here it is 1, 2, 3, 4, 5, 6, 7, 8, or 6 or 7. Here it is just 50. 50, 2 direct, 150. QRS complex, check QRS complex. Check QRS complex. Wide QRS complex, narrow QRS complex. Wide, narrow QRS complex, wide QRS complex. Wide QRS complex, narrow QRS complex. RR distance, see RR distance, see RR distance, see RR distance. How abnormal RR distance is here. Now tell me, which was normal, this or that. Can you identify all these problems here? See, going T wave upward or higher is not abnormality. Okay, the base is base. Okay, it is not abnormality. If you're saying that T wave is here, T wave is not touching the line. No, line means where it is touching this junction. ST junction origin is touching that line. ST junction origin is touching this line. ST origin junction is touching this line. ST origin junction is touching this line. ST origin junction. QRS complex. ST junction is at the same point with this line. Okay. So tell me, guys. Yes, understand the difference between abnormalities. So, would you be able to do that? Do you understand or not? If any questions, please ask me. We should not go, to the next slides if you're not understanding it. Did you understand? How many of you understood this? Tell me, guys. Yes. Understood but not confident. Okay. What is the problem? Tell me. Like, I'll explain it again. Tell me, where is the problem? Where do you find it tough? See, why I kept this intentionally is because you will be confused after seeing the mess. Okay. Like here, T wave is less. Here, T wave is upward, downward. Here, T wave is very, very high. Okay. How did you differentiate it if this was T wave? Very nice question, T wave or P wave. I mean, really very nice question. See, I'll show you that. I'll explain this. Okay, any other questions here? Any other questions, guys? See, look at me and look at the slides clearly. Okay. Here, let's start from the first. Let's start from the. Where is the ledger? Okay, let's start from the first wave. Okay, I mean first rhythm. So if you check, this is a pattern. See, this is QRS complex. After QRS, T. After T, there will be P wave. So here you can see that is visible P wave, simple P wave. So this is a normal rhythm. This is a normal rhythm, right? There are no 3 or 4 waves, only PQRS complex, I mean QRS complex, then T, then it starts with again P, QRS complex, T. Okay, if you look at this, see, this is QRS complex, T, and after the T wave, this is P wave. There are no 2 waves after T. There are no 2, 3 waves after T. There are specific, there is no difference. Okay. I mean, there is no different kind of rhythm here. Okay. Whatever is the pattern, look at the pattern. QRS complex, T wave, P wave. QRS complex, T wave, P wave. There is no another wave. See, you have to differentiate, like if there are only 2 waves between PQ, I mean between R and R. If there are only 2 waves or 2 fluctuations between R and R, that will be T and P. Okay, if there are 3 or 4, that could be abnormality, and those also will not be will not be different. See, these are different waves. This is taller, this is smaller, this is taller, this is smaller. So smaller one is P. In the flutter, everything will be same. Everything will be like jigsaw level. Okay, we saw a tooth saw, right? You have seen the tooth saw or jigsaw. So everything will be like this. No, not like this, not like this, not like this. Jigsaw or tooth saw, it is like it will be similar. Flutter, that is called flutter waves, or that is called fibrillation wave. Okay, fibrillation waves. Okay, then there is similarity. This is consistent. This is consistent and following the ECG, normal ECG pattern. QRS complex, QRS complex, T wave, P wave. QRS complex, T wave, P wave. Here, look at this. QRS complex, T wave, P wave. QRS complex, T wave, P wave. QRS complex, T wave, P wave. And here it is visible. If you see there is no P, then you can see there is a little upward. Okay, this is here. This junction, you can see the P wave clearly. At this red point, you can see the P wave clearly. Here at this point, you can see the P wave. Here it is most visible. Here also, if you see this, this is QRS complex, very low QRS complex. Okay, very low QRS complex. But after that, you can see one wave here and one a little, very little, one T wave here and one P wave here, T wave here. And if it is not visible in third, okay, it's okay. If it is not visible in third, you will say, sir, it is not visible. You are just simply saying, okay, let it be. Consider it is not visible at all. P wave is not visible in third. But if the P wave is absent, it should be absent from all lateral and rear views. It should be absent from all the entire ECG. If the P wave is absent in the AF phenomena, or I mean atrial flutter or atrial fibrillation phenomena, it will be absent everywhere. Okay, so here it is just because of the low voltage, it has not been visible. Here it is not absent, it is just not visible because of the low voltage. Okay, understand, it is not visible because of the low voltage, but it is there. Okay, and here check and others like P wave, clear P wave, clear P wave, clear P wave, here clear P wave, here clear P wave, right? If the P wave is absent in AF phenomena like atrial flutter or atrial fibrillation, that will be absent from all the rhythms, all the waves. Understand? So that is what you have to understand. Like, that's how confidently I can say it is following the QRS complex and TP complex phenomena, and I can say this is T, this is P. Okay, and in that I cannot say because there is a flutter phenomena. There are phenomenons, right? There is flutter, there is no differentiation. Okay, and this is a consistent normal ECG phenomena. That's why I can say this is T, this is P, because like this is how the ECGs are printed. This is how the ECG are printed, and this is how you read the ECG. Like QRS complex, T wave, P wave. QRS complex, T wave, P wave. I will be surprised if there is any another wave, or this one wave will be absent. I'll be surprised in that case. So there is nothing rocket science like you cannot understand. It's very simple. Okay, it is very simple. Yes, I know it needs very much practice. It needs a lot of practices. So what you can just go to the internet in Google. You can go to the images, right? The AF ECGs, hundreds of ECGs will come. Okay, read one by one, read one by one, read one by one with explanation. Okay, you will understand. You have to practice. Okay, then only you can be master of ECG. You cannot just say in one go or second, two go, three go, because there are complex ECGs also. But the phenomena of understanding, QRS complex, T wave, P wave is very simple. Okay, understanding there are five phenomena as I told you. Like there are five criterias: ectopic beats, heart rate, magnitude line, and your P wave, QRS complex. So it's very simple to understand. Okay. See, so sinus tachycardia, how to diagnose? Definitely, as we diagnose bradycardia, electrocardiogram, ECG, echo, Holter monitoring, chest X-ray also we can do, chest CT also we can do, and some blood tests to find out why it is happening. Like maybe it can happen because of low hemoglobin, it can happen because of the hyperthyroidism, it can happen because of certain cases, and if it is happening because of some some kind of chest infections, tuberculosis, tuberculosis, or maybe it is happening because of the what we say that some other heart diseases like cardiomyopathy and all, it will be seen in chest X-ray. Okay, pulse oximetry to check how much oxygen is in your blood, right? So to check your blood oxygen, we can check the pulse oximetry also, and scan to check the circulation in blood. Circulation of your blood in the lungs also we can check. So these are the normal diagnosis criteria how we follow, right? And then what is the treatment of sinus tachycardia? Usually beta blockers we give. metoprolol, carvedilol, or any other beta blocker, right? There are many. Propranolol is not usually used. Propranolol is very old generation drug, but nowadays carvedilol is there, or metoprolol is there, right? So those things can be easily used in this. And then ivabradine is there. Okay, ivabradine is the new age drug which is being used in cardiac conditions to reduce the heart rate. Okay, and then calcium channel blockers also. And if there are any surgical interventions needed, we go for catheter ablation and cognitive behavioral therapy. If you are stressed out, right? So there are multiple things could be used for treatment or management of sinus tachycardias. But how we can prevent it? You can prevent some of the causes by staying calm, healthy, and hydrated. Okay, you can reduce the risk of tachycardia, sinus tachycardias, usually by staying calm, healthy, and hydrated. Reducing caffeine intake. Always I'm coming and stuck here only. Caffeine intake, you have to reduce your coffee. Okay. Exercise regularly. Quitting smoking and using tobacco products also can prevent sinus tachycardia. Consuming less sodium. Okay. Salt is again the problem, because salt can uh, alter your what we say, that electrolytes in the body, and that can lead to dehydration or cardiac overload when your electrolytes are imbalanced, right? So that's why always try to use less salt also, if you want to prevent tachycardia, sinus tachycardia. Okay, so there could be multiple reasons, there could be multiple things which can lead to that, and which you can prevent. Okay, so this is, again, now let's come back to this. So what is this tachycardia, guys? What is this tachycardia? Tell me. Why T wave in V2 to V6 not relevant? Not relevant means what? T wave in V2, V3 and V4 not relevant. I didn't get you relevant. Rang, I didn't get you. What do you mean by relevant? In the previous one, right? You're talking about this. Where is no relevant? You are telling similar. Similar or relevant? No, no. See, this is just a high heart rate, and because of the high heart rate, sometimes this is just a voltage difference. This is just a voltage difference, but phenomena is normal. The criteria of the rhythm is normal. There is voltage difference, that's all. Voltage difference could show the high T wave, tall T wave, or lesser T wave, or P waves. This is because of voltages. The problem is with voltage. Okay, and those voltages are influctuating or fluctuating because of the person has come just after the exercising, right? So in the body, the overload of or the oxygen supply and a lot of things which can lead to the print, what we say, the this is in the voltages, right? Voltages are fluctuating here, right? There is no inconsistency, there is no irrelevancy, all everything is similar. Okay, pattern is similar, just the voltage is problem here. Okay, now this, so this is AF. Okay, this is AF. How I can say it is AF? Because see, there is no P wave, there is no P wave. Where is T wave, where is P wave? Maybe there is T wave, but there is no P wave, right? You can see ST, QRS complex, right? QRS complex, and after that T, but there is no second wave. Phenomena is incomplete here. QRS complex T, no P wave. Here QRS complex T, but no P wave. Here QRS complex, T is here, but no, QRS complex is there, but no P wave, no P wave. Okay, here QRS complex, little T wave, no P wave. Little T wave, this is T wave. QRS complex, this is T here, no P wave. Here in this QRS complex, T inversion, no P wave. Or here it is flutter, T wave and then two waves, right? It is flutter. Okay, here it is completely flutter. Multiple waves between, QRST or RR, multiple waves. This is flutter form. This is, flutter phenomena. This is fibrillation phenomena and flutter phenomena. Okay, here if you see, P wave is completely absent. Here P wave is completely absent because this is flutter formula. The jigsaw or tooth saw phenomena, we call it tooth saw phenomena. Okay, and here no P wave, right? Here no P wave. This is just QRS complex, and T, no P. QRS complex, no P. Okay. QRS complex, no P. Okay. And if you say one or two P somewhere, maybe you are seeing this P wave. This is not P wave. This is again T and similar, correct? Similar wave. This is tooth saw phenomena. Okay. Here also, this is tooth saw phenomena. Here also, this is tooth saw phenomena. Okay. So P wave absent first thing, and irregular beats, right? Irregular, inconsistent RR distance. RR interval is inconsistent completely, and your magnitude line. See, if I just consider this, then it will go like this, right? It is not touching now. See, it is not touching now. It is not touching now. Here it is not touching now. So this is inconsistent line. Okay. And QRS complex is also different. See, here it is wide. Okay. And here it is, very narrow, and heart rate, not heart, I will not say heart rate, but inconsistency in the beats, inconsistency in the beats everywhere, right? So this is the AF phenomena. This is the atrial fibrillation phenomena. So atrial fibrillation is most common sustained arrhythmia. It is characterized by disorganized atrial electrical activity and contraction. So that means the atria got a problem, right? The upper chambers of heart got a problem, right? Upper chambers of heart got a problem. Those are not into the proper conduction. Okay, those are not into the proper conduction. That's why we are getting the different thing. Everything is disorganized now. P wave, this is not absent, and your magnitude line completely disorganized. Your QRS complex completely and RR interval completely disorganized. Everything is disorganized here, right? And then this incidence and prevalence of AF is increasing. Lifetime risk over the age of 40 years is 25%. Okay, so it is reducing the life expectancy by 25% in the people if there is AF by 25%. Understand? By 25%, it is decreasing your lifespan. Okay, if you have AF and in more than 40 years of the age, it is reducing your chances by 25%. Complications of AF includes hemodynamic instability, cardiomyopathies, cardiac failure, or embolic events like stroke or cardiac arrest. The patient can be into the serious troubles because of atrial fibrillation. Understand? Now, let's see. Look at this ECG features of atrial fibrillation. Look at this. See, look at this. Look at this. Can you see anywhere? Like, see, first thing, irregular rhythms. Irregular rhythms. There is no consistency, even like 1:2 ratio or 2:1 ratio, right? There is no inconsistency. I mean, there is no consistency even in that. Like, okay, this is bigger, this is smaller, this is smaller, then bigger, then smaller, bigger, then smaller, bigger, then there is no consistency at all. So these are called as irregular rhythm. Okay. No P waves. Where is P waves in that? Can you see P waves? I cannot see because this is a jigsaw phenomena. Okay. You can see this apart, like multiple rhythms. You can see here multiple another waves like F waves or U waves. Okay. Fibrillation waves. Okay. These are fibrillation waves. These are not P waves. There is no P wave. These are fibrillation waves. See, 1, 2, 3, 4, 5. Four waves, three waves. 1, 2, 3, 4, 5 waves. 1, 2, 3, 2 waves. 1, 2, 3 waves. So this phenomena is completely different. No P waves. Absence of an isoelectric baseline. There is no isoelectric baseline or magnitude, electrical magnitude baseline. There is no baseline at all. Where is baseline here? There is no baseline at all, right? Neither it is starting nor it is ending. It is just it is just jig everywhere, right? There is no isoelectric baseline also in atrial fibrillation, right? Variable ventricular rates, absolutely. RR interval is very different at every, so ventricular rate is different. QRS complex usually less than 120 milliseconds, right? Unless pre-existing bundle branch block, accessory pathways, or rate related aberrant conduction is there, then only it will be more than 120 ms. Otherwise, less than 120 milliseconds is QRS complex, right? It is quite narrow QRS complex. Okay. And then fibrillatory waves may mimic P wave, leading to misdiagnosis. See what I was telling. Fibrillatory waves are it can lead you to the P wave. See, you can see, oh, this is P wave, sir. This is there is no P wave. This is P wave, sir. Or there is no P wave. This could be P wave. This could be P wave. This could be P wave. How can you say there is no P wave? This could be P wave. No, because these are fibrillatory waves. In atrial fibrillation, called fibrillatory waves. In atrial flutter, flutter waves. Okay, these are fibrillatory wave. So the whole diagnosis of atrial fibrillation you can understand here: irregular rhythm, absence of isoelectric baseline or magnitude, electrical magnitude baseline, and no P waves, variable ventricular rates, and fibrillatory waves, which can mimic P values. Okay. So, did you understand, guys, here? Why flutter is present in? No, flutter is not present. This is not flutter. Flutter is present in this article. In this, if you see in only only one wave, actually V1, you can see the flutter mimicking waves. But this is not flutter. If this is flutter, it will be everywhere. It will be in the whole ECG. If there is flutter, it will be in the whole ECG. But here you can see it is fibrillation. It is fibrillation. It is fibrillation, not flutter. Okay. So flutter mimicking waves are there in V1. That's all. Okay, guys, understand now. Questions? Any questions here in AF? Any questions here in AF? Anything you want to ask? Anything you are not understanding? Tell me, guys. Tell me fast. Anything you're not understanding? Yes. Yes, people, ask me questions. This is a very interesting class, actually. Yes. Yes. Anyone wants to speak or wants to ask questions? Reasons of absence of isoelectric baseline, because see, because it is completely abnormal. Okay, it is completely abnormal voltage. Okay, a line comes when there is consistent voltage. So there is no voltage consistency. There is no voltage consistency. So that's why there is no line. Right, line will come when the things are consistent, right? But if things are not consistent, there will be no line. Right, I mean, line is there, but zigzag line. There is no isoelectrical line. Okay, there is no isoelectrical line. How to check variable ventricular rate? Variable what? Rishra, it is very simple. Very variable ventricular rate is similar, just RR, consistency, heart rate. As we check heart rate, here we cannot check heart rate because it is different at different point of time. But you can check this RR interval. You can check RR interval. Okay, how much it is? Different variable waves. Like, okay, this is around 300 maybe. This is around 300. This is around 150. This is 300. This is less than, I mean, more than 300. This is 300. This is around 150 to 160. This is 300. This is around 200. This is around 250, 230. This is around 200. Okay, this is less than, I mean, this is more than 300. This is variable ventricular rate. See, this is ventricle rate, RR intervals. This is variable ventricular rate. Okay. Heart rate in such, it is like you can calculate the average. Okay. You can calculate the average heart rate in this, or the machine usually gives the heart rate, right? Average heart rate we calculate in this. Okay. Average heart rate. Okay. Any other questions? Any other questions, guys? Yes, people. You understand or not? If no, I will make it understand. Can we rely on pulse oximeter for HR in such cases? You can definitely, but it will not be similar every time. Every minute it will be changing. Every minute it will be changing. So you can rely like on the pulse oximeters, or maybe in different phenomena. You can check by yourself. But yes, it will be changing because as it is the fibrillation, okay, or flutter. Okay, so you have to be very, very careful in HR because it will be increasing, decreasing in seconds, within seconds, like within seconds. Okay, yeah. Any other questions, guys? Yes, people. Did you understand? If no questions, did you understand? Everyone. Did you understand? Anyone? Yes, people. One sec, guys. Yes, guys. So you understood or not? This. Okay, fine. If you understood, wonderful. Okay. So this is mechanism of action of atrial fibrillation. You were asking why there is a problem. Why there is a problem? There are two types of problems in AF. If you look at the left side or right side. Okay, see, these are your left atrium. This is your right atrium. This is your left atrium, and that is your. Okay, so let me use the laser. See, this is your left atrium. This is your right atrium. Okay, this is inferior vena cava. This is superior vena cava. Okay, inferior vena cava, superior vena cava, and these are your pulmonary arteries. Okay, in pulmonary arteries. So why AF happens is when your SA node is default, I mean, or is faulty, not default, is faulty. When your SA node is faulty and your AF, I mean, your, atrium is also having the problems and the pulses or the, your, what we say that your pulse impulses are generated from anywhere else, and usually there are two forms of generation of these impulses, generation of these voltages. There are two things. One, it generates near to the pulmonary arteries, from where the pulmonary arteries generate, I mean, originates, right? From here the pulmonary arteries are originating in the atrium region, in the atrium region, and that's why the origin of impulses or voltages is from here. Okay, and this is just having the whole phenomena or whole re-entry format or focal activation in the upper chambers only, left atrium to right atrium to left atrium to atrium, and this is creating the mess. This is creating the various impulses, or not only the various irregular impulses, irregular rhythms or irregular voltages. Okay, that's why the ECG captures multiple irregularities. That's why it captures multiple irregularities. And why not P waves? Because the impulses or the voltages are not generated by SA node here. Okay, the impulses are not generated by SA node properly. So that's why there is no P wave. P wave is absent because the generation of impulses or generation of voltages, the origin of voltage is somewhere else, that is near to pulmonary artery, and because of that the voltage difference is there, and the voltage which generates the P wave in print format, that is completely absent. Those voltages are absent, right? So that is the first MOA of atrial fibrillation. And second is reentrant formula. Okay, reentrant wavelets. Okay, so this is like maintained by re-entry circuits. So if these are also coming from SA node, usually not again SA nodes, usually from somewhere else, like maybe near to PA, near to pulmonary arteries, there is the origin of these impulses near to pulmonary artery. But what happens here is it goes out of RA, but again comes to RA. It is not going to ventricles. The waves are re-entering again and again. Multiple wavelets are entering again and again to RA. Okay, I mean RA or LA, right? I mean atriums, right? If you see this here, see this was generated from here. came out, again re-enter. Here it went to RA, came out of RA to the other chambers like ventricle maybe, or out of ventricle, inferior vena cava, superior vena cava, came in. Okay, so these impulses are re-entering again and again, multiple small wavelets in the, and then maintained by re-entry circuits. Okay, re-entry circuits. These are the re-entry circuits of these wave. Okay, multiple wavelets, re-entry circuits are there, and these are causing the irregularity in the heart. These are causing or creating the irregular heartbeats or irregular uh, wavelengths of impulses or voltages. Okay, irregular wavelengths of impulses or your impulses, right? Or so this is causing the AF, irregularity in heartbeat, irregularity in impulses, irregularity in your the whole system. Okay, that is creating, because the entire part which must be generated, this voltage generation must be from SA node. It is not happening from there. It is mixed, and it is usually happening from the pulmonary vasculature or near to pulmonary arteries. Okay, so this usually happens in atrial fibrillation when it happens. Okay, you can see, understand AF. This is normal sinus rhythm. This is atrial flutter. You saw tooth saw. Tooth saw formula, tooth saw phenomena is a flutter waves. All it is flutter, flutter, flutter everywhere. Okay, in atrial fibrillation, you will see there is a tooth saw formula phenomena, but this is fibrillation. This is not flutter. Flutter means everywhere it will be same only, right? In the fibrillation, the different waves, but different waves, but irregular. Here in flutter, there will be the flutter waves, but regular. Okay, there's a difference between AF like atrial flutter and atrial fibrillation. Fibrillation is completely irregularly irregular. Okay, in atrial fibrillation, it is like irregularly regular. Okay, irregularly regular, right? So the wavelength, or sorry, the RR intervals, and the type of waves is similar here. Okay, is similar here, right? Not a correct phenomena, but it is similar here. It is regular here. Here it is completely irregular, right? Seesaw formula is seesaw phenomena is there in the AF also, in the atrial flutter also, atrial fibrillation also, but there is a difference. Irregularity is the characteristic of fibrillation. Irregularity everywhere. Irregularity in RR interval, irregularity in waves, irregularity in the voltages. It is irregular. Okay, irregularity is characteristics of atrial fibrillation. Irregularity in everything. Okay, and that is because the origination of your voltages is different. Okay, causes of atrial fibrillation: ischemic heart disease, hypertension, valvular heart disease usually, acute infections, electrolyte disturbances like hypokalemia, hypomagnesemia, thyrotoxicosis, drugs like sympathomimetics could be there, alcohol consumption, pulmonary embolysis, embolus, or pericardial disease, acid-base disturbances, pre-excitation syndromes, or cardiovascular, cardiomyopathies like dilated cardiomyopathy or hypertrophic cardiomyopathy. So these are the causes of atrial fibrillation, or pheochromocytoma is the another reason for these things. Classification is there. So till now, tell me, guys, did you understand this? Whatever we are studying, did you understand or not? Yes, did you understand or not? Are you understanding this? Okay, great. So classification, there are classifications. There are multiple types of AF. So classification is dependent on the presentation and duration of AF, right? So first episode AF is which is initially detected, okay, regardless of symptoms and duration. If it is the first episode AF, this is first episode. Okay, EF is first episode, like first time in the life is happening. Okay, then recurrent AF, more than two episodes of AF. If someone got, if someone got just one episode of AF, that is called first episode AF. If it is recurrent AF, like if it is appeared more than two episodes in any time of, any duration, like one today, one after 10 days, 50 days, 1 year, 2 year, doesn't matter. But if it appeared two episodes of AF, that is called recurrent AF. Okay. Proximal AF is self-terminating episode in less than 7 days. If the AF is there and if self-terminated, okay, if it goes, by itself, if the symptoms goes by itself and within less than 7 days, that is called proximal AF. If it is not self-terminating and it is, persisting for more than 7 days, that is called persistent AF. Okay, long-standing AF is more than 1 year. Long-standing AF is like on and off episodes, but more than 1 year. It is called long-standing persistent AF. Permanent accepted AF is duration is more than 1 year in which rhythm control interventions are not pursued or are unsuccessful. Right, like there was AF, you tried medicines, there is no improvement. Okay, AF is still persisting. Okay, AF is still there for more than 1 year. That is called permanent AF. Okay, so these are the terms you have to remember. First episode for first time, recurrent AF for more than 2 episodes of any AF and irregular, regardless of symptoms or duration. Proximal AF self-terminating within 7 days. Persistent, not self-terminating, duration more than 7 days. Long-standing more than 1 year. Permanent more than 1 year, where drugs have been tried or are unsuccessful. Are not tried or unsuccessful. Okay, interventions are not tried or unsuccessful. Okay, so this is classification. Management of atrial fibrillation, definitely very important. Like first you have to diagnose the proper type, assessment of duration, assessment for anticoagulation if the anticoagulation has been given or not, because it can lead to the coagulation related problems, or it can lead to thrombus formation, right? It can lead to stroke, cardiac arrest, myocardial infarctions, many things from like thrombus related problems. It can help thrombus creation. So definitely anticoagulation is the treatment part, right? Rate and rhythm control, like maybe beta blockers we can give, or ivermectin we can give, or other medicines for rate control can be given. Okay, then definitely treatment of underlying or associated disease like hypertension or maybe other problem which can create AF, right? Or infections or something. So it can help in management. Medications, beta blockers, calcium channel blockers. So beta blockers help slowing the heart rate and rest and during the rest and activities. Calcium channel blockers also. These medicines control the heart rate, but may need to avoid by those who have heart failure or low blood pressure. Right. So calcium channel blockers cannot be given in hypotensive patients, or heart failure patients. Digoxin can help in controlling the heart rate, but not as well during the activities. Antiarrhythmic medications are there, multiple other like ivermectin. I told you, ivermectin can be can be tried. Blood thinners, like definitely anticoagulants are needed. Usually clopidogrel we give, or maybe warfarin we give, right? Or acinocamerol, acetron we call it, acinocamerol we give as a blood thinner. So there is a less risk of blood clots formation and less risk of stroke or myocardial infarction in the patients who have AF. So we keep them on the blood thinners, or like acinocamerol, warfarin, and all, right? These are the medications. Cardio version in atrial fibrillation. Okay, so guys, I think we should stop this because this is the therapy for other tachycardias also. So I will stop it here because this could be later. This could be we can discuss this later when we are studying other type of arrhythmias also. Okay, so today AF and sinus tachycardia. Okay, sinus tachycardia and AF. So any questions, guys? Now tell me, any questions for today, or did you understand or not today's class? Yes, everyone. Did you understand the class or not? Yes, guys. Understood. Very nice. Fantastic. No, there is no feedback. There is a digital attendance now. Your digital attendance is being taken. Don't worry. Okay. Attendance is being taken digitally. You don't have to worry. If you want, we will share the attendance for today. Don't worry. Okay, guys. Any questions? Any questions? Okay, if no questions, then guys, thank you very much and see you. Bye bye. Thank you,
Thank you,
guys.
sir.
Thank you, ma'am. Thank you very much.
Thank you, sir.